Knee osteoarthritis, often referred to as knee OA, is one of the most common joint disorders worldwide. It's a degenerative condition that affects millions, especially as people age. The disease is marked by the gradual breakdown of cartilage in the knee, leading to pain, stiffness, and reduced mobility. While it's more common in older adults, factors like obesity, previous injuries, and genetics also play a significant role. In this video, we'll explore the underlying mechanisms of knee OA and review the latest non-surgical management options. Our journey begins by understanding what makes knee OA such a widespread and impactful health issue. Knee OA is a global health concern, affecting over 250 million people. Its prevalence increases with age, with up to 10% of men and 13% of women over 60 experiencing symptoms. But age isn't the only risk factor. Obesity, previous joint injuries, and genetic predisposition all contribute to the likelihood of developing knee OA. Women, particularly after menopause, are at higher risk. As we look at the numbers, it's clear that knee OA is not just a problem for the elderly. Lifestyle and health choices throughout life play a big part in determining risk. Looking ahead, the prevalence of knee OA is expected to rise sharply, especially in developed countries like the UK. By 2040, millions more will be affected, driven by an aging population and increasing obesity rates. This trend will place a growing burden on healthcare systems, making prevention and early intervention more important than ever. Planning for this future means understanding the demographic shifts and the impact of lifestyle factors so that resources can be allocated effectively and new strategies can be developed. The impact of knee OA goes beyond personal discomfort. It's a leading cause of disability and work loss, with healthcare costs expected to exceed $250 billion globally by 2030. In the UK alone, the annual cost of managing knee OA, including surgeries, is projected to surpass £3.5 billion by 2035. These expenses cover medications, physical therapy, surgeries, and the indirect costs of lost productivity. As more working-age adults develop OA, the economic burden will only grow, highlighting the need for effective preventive and management strategies. Knee OA is more than just worn-out cartilage. It's a complex disease involving the entire joint, including cartilage, subchondral bone, synovium, and surrounding tissues. The articular cartilage loses its resilience, subchondral bone undergoes remodeling, and the synovial membrane becomes inflamed. These changes lead to pain, stiffness, and functional decline. Interestingly, the severity of symptoms doesn't always match what's seen on imaging, as factors like pain processing and psychological state also influence how OA is experienced. Articular cartilage is a unique tissue, made mostly of water, type II collagen and proteoglycans. Chondrocytes, the only cell type in cartilage, maintain a delicate balance between building and breaking down the extracellular matrix. Mechanical loading, how much you use your knee, plays a big role. Too little activity leads to thinning and softening, while too much causes irreversible damage. When this balance is lost, cartilage breaks down faster than it can be repaired, setting the stage for OA. Beneath the cartilage lies the subchondral bone, which also changes in OA. It consists of a dense plate and a spongy layer, both regulated by bone cells responding to mechanical and chemical signals. OA leads to bone lesions, cysts, and osteophyte formation. The synovial membrane, which lines the joint, becomes inflamed and thickened, producing inflammatory mediators that further damage cartilage. This interplay between bone, cartilage, and synovium is central to OA progression. Inflammation is a key driver of knee OA. The synovium releases cytokines, chemical messengers that can either promote or reduce inflammation. In OA, pro-inflammatory cytokines like IL-1 and TNF-alpha dominate, activating enzymes that break down cartilage. Anti-inflammatory cytokines try to counteract this, but often can't keep up. These biochemical changes not only damage the joint, but also influence pain and disease progression, making inflammation a major target for future therapies. Obesity is a major risk factor for knee OA, not just because of extra weight on the joints, but also due to metabolic effects. Fat tissue releases substances called adipokines, which can promote inflammation and cartilage breakdown. Obese individuals are 4 times more likely to develop knee OA, and they face higher risks of complications after surgery. Managing weight is therefore a crucial part of both preventing and treating knee OA. Genetics also play a role in knee OA. Over 90 genetic loci have been linked to OA development, affecting how cartilage and bone respond to stress and injury. Epigenetic factors, like microRNAs, regulate gene expression and can influence disease progression. Disruptions in these regulatory systems may set the stage for OA, especially when combined with mechanical or metabolic stress. This area of research is opening new doors for personalized therapies. Pain is the most prominent symptom of knee OA, but it's a complex experience. Pain can arise from multiple tissues in and around the knee, driven by inflammation, nerve growth, and biochemical changes. Central mechanisms in the spinal cord and brain also modulate pain, sometimes making it worse even when joint damage is mild. Understanding these pain pathways helps guide more effective, individualized treatment strategies. Physical therapy is a cornerstone of knee OA management. Exercise programs that combine strengthening, aerobic, and functional exercises have been shown to reduce pain and improve mobility. The key is to tailor exercise to each individual, considering age, comorbidities, and personal goals. Adherence to exercise is the best predictor of long-term success, so finding enjoyable, sustainable activities is essential. Even low-impact activities can make a big difference when started early and progressed gradually. Heinzio tapping and knee braces are additional tools in managing knee OA. Tapping can help reduce pain and improve function, though evidence is mixed. Knee braces, especially custom-fitted ones, can offload stress from affected areas and improve stability. However, comfort and adherence are key. Many patients stop using braces within 6 months. The right choice depends on individual needs, body type, and OA severity. Special insoles and footwear are sometimes recommended for knee OA, especially when one part of the knee is more affected. The effectiveness of these devices varies, depending on their design and how consistently they're used. Some patients find significant relief, while others notice little change. More research is needed to determine which types work best for different people, but they remain a non-invasive option worth considering. Topical treatments such as capsaicin, NSAID creams, and salicylates offer pain relief with fewer systemic side effects. Capsaicin, derived from chili peppers, works by reducing pain signal transmission. Topical NSAIDs are often preferred over oral forms for knee OA, especially in older adults or those with other health risks. These treatments are easy to apply and can be combined with other therapies for added benefit. Oral medications remain a mainstay for symptom control in knee OA. Acetaminophen, NSAIDs, tramadol, and duloxetine are commonly used, each with its own benefits and risks. NSAIDs are effective but can cause gastrointestinal, cardiovascular, and kidney side effects, especially with long-term use. Selective COX-2 inhibitors may reduce GI risks but increase cardiovascular concerns. It's important for clinicians to tailor medication choices to each patient's health profile and monitor for adverse effects. Intra-articular injections of hyaluronic acid are widely used for knee OA, especially in early or mild cases. These injections aim to restore joint lubrication and provide short-term pain relief. While they are generally safe and well tolerated, their long-term benefits remain uncertain. Some patients experience significant improvement for several weeks or months, but repeated injections may be needed. Corticosteroid injections are another common option for managing knee OA pain. They provide rapid, short-term relief, typically lasting a few weeks. However, repeated use can lead to diminishing returns and potential side effects, such as cartilage damage or systemic effects. The choice of steroid, dose, and injection technique should be individualized, and most guidelines recommend limiting injections to a few times per year. Emerging therapies like platelet-rich plasma, PRP, and mesenchymal stem cells, MSCs, are gaining attention for their potential to repair cartilage and reduce inflammation. PRP uses the patient's own blood components to promote healing, while MSCs can regenerate tissue and modulate immune responses. Although early results are promising, more research is needed to standardize protocols and confirm long-term safety and effectiveness. Disease-modifying osteoarthritis drugs, DMOADs, represent a new frontier in OA treatment. These medications aim to slow or halt cartilage degeneration by targeting specific enzymes and signaling pathways. While animal studies show promise, clinical success has been limited so far. Ongoing research is focused on finding safer and more effective agents that can truly change the course of OA, rather than just managing symptoms. Several experimental treatments are on the horizon for knee OA. Genicular artery embolization targets blood vessels to reduce inflammation and pain. Anti-obesity medications like semaglutide may lower OA risk by addressing metabolic factors. Anabolic agents, growth factors, and tissue engineering approaches are being explored to promote cartilage repair. Monoclonal antibodies targeting specific molecules in the joint are also under investigation. While these therapies are not yet standard care, they offer hope for more effective, personalized treatment in the future. So many options available, the best approach to knee OA is often a combination of therapies tailored to the individual. This might include exercise, weight management, medications, injections, and supportive devices. The goal is to reduce pain, improve function, and delay or avoid surgery. As research advances, personalized treatment plans that consider each patient's unique needs and disease stage will become increasingly important. Despite progress, challenges remain in managing knee OA. Many treatments provide only modest relief, and no current therapy can fully stop or reverse the disease. Access to care, adherence to treatment, and health inequalities also affect outcomes. Continued research is needed to refine existing therapies, develop new ones, and ensure that all patients can benefit from advances in OA management. The future holds promise, but also requires ongoing commitment from clinicians, researchers, and patients alike. Knee osteoarthritis is a complex, multifactorial disease that affects millions worldwide. While non-surgical treatments can reduce symptoms and improve quality of life, they rarely halt disease progression. Emerging therapies offer hope, but more research is needed. Ultimately, a personalized, multimodal approach, combining lifestyle changes, medications, and innovative treatments, will be key to managing knee OA and improving patient outcomes. Staying informed and proactive is the best way forward.